Very excited to host this panel and to introduce you to some wonderful colleagues as we discuss health disparities in suicide-related behavior and care. Our prior presentations are tough acts to follow. It's really great to have this space together. As a health services researcher, I study healthcare disparities and clinical innovations in suicide prevention with a focus on minoritized and disadvantaged families. And in recent years, it's become clear that suicide is disproportionately affecting certain groups. You may be familiar with research that's documented a rise in suicide-related behavior and death among Black and Latinx individuals, especially children, how the COVID pandemic has likely exacerbated such trends. Valuable surveys like the information we get from the Trevor Project tell us that suicide attempts are relatively really high among transgender and non-binary youth. At the same time, new state supports, such as community behavioral health centers and federal supports like the 988 Lifeline, offer strong policy approaches to suicide prevention. So this morning, our discussion will consider how suicide disparities research is hindered by limitations in available data. We'll discuss how engagement with community stakeholders can improve our understanding of suicide-related behavior and promising interventions. We'll share thoughts about policy successes and challenges to improve suicide-related disparities, all while inviting your really valuable questions for our panel. So the way we're going to proceed here is I'll introduce our first panelist, and then they will give their 5 minutes of thoughts, and then we'll proceed through the group in that way. And I'm very excited to introduce Dr. Margaríta Alegria first. Dr. Alegria is the chief of the Disparities Research Unit at Mass General Hospital and the Mongan Institute. She's a professor in the departments of medicine and psychiatry at Harvard Medical School. Dr. Alegria has spent her career examining how to reduce health disparities for populations of color, immigrants, and linguistic minorities. She's currently the PI of 3 NIH-funded research studies, and these are called Building Infrastructure for Community Capacity in Accelerating Integrated Care, Building Community Capacity for Disability Prevention for Minority Elders, and Latino Youths Coping with Discrimination, a multi-level investigation in micro and macro time. Dr. Alegria has published on improvement of healthcare services delivery for diverse racial and ethnic populations, conceptual and methodological issues with multicultural populations, and ways to bring the community's perspective into the design and implementation of health services. Welcome, Maggie. Thank you so much for joining us.
Thank you so much, Nick. I'm really excited to be part of this panel and actually with my colleagues that have been working in this for such a long time. Let me talk. I was going to just chime in into 2 areas that I think are really important. And you mentioned policy. And I wanted to raise the issue of policy because it is one way in which we can really move the needle of disparities in a way that transforms what we are offering right now. I wanted to cover 2 areas that I find in my 5 minutes are so important. The first one is, policy with the Mental Health Parity and Addiction Equity Act that's supposed to roll out in 2026. And this is really a huge, huge event because it will really allow us to hold insurance companies accountable for practices that prevent many people from getting mental health care. For example, it'll deal with co-payments, with deductibles, with co-insurance, with annual or lifetime number of outpatient visits and inpatient visits. So this is major to hold insurance companies accountable. Nick, we know that when people have a service like this in their setting, they have 3.5 times more often to be able to see a behavioral health clinician, 9 times more likely to see a psychiatrist, 10 times more likely to see a psychologist, and 6 times more likely to get inpatient care. So this is huge. This policy change is going to make a big difference. The other one, like you said, is 988. I think the 988, we have more than 10.8 million calls that have been done to 988. The 988 is a three-digit connecting people to suicide and crisis lifeline. This is administered by SAMHSA. You could do it by phone, by call, by text. Actually, text is increasing quite dramatically. And it really has focus on trying to do a good job. I think it does have problems that we need to address. Like it's right now, the services are available in English and Spanish, but we know that it's missing a lot of populations, linguistic minorities that don't speak either of those languages. I think the other amazing and important factor that we need to think about is the Biden administration is expected to allot an additional 700 million, not only for the line, but also for crisis centers. Because one of the things we need to think about in the whole area of the continuum of care, it's not only the call, but it's actually connecting the person to services and available services nearby. So I think this allotment of 700 million to crisis centers, it's going to be amazing. And this was done in 2023. It, however, requires still for states to do a lot of the additional funding. And we know only 13 states have put additional funding through telecom taxes, and another 10 have changed legislation, but there's still a lot to do to create the continuum of care. So I'm going to stop there, but I think it's so important to make sure that we build that continuum of care with policy decisions, more funding for the services. Thank you, Nick.
Thank you very much, Maggie, for the starting with the big picture. So that's really helpful for understanding what's to come and what potentially is available to us from different levels of government. Next, we'll hear from Dr. Benjamin Lay Cook. Ben is the director of the Health Equity Research Lab here at Cambridge Health Alliance. He's a professor in the Department of Psychiatry at HMS, and he's a visiting clinical associate professor at the Albert Einstein College of Medicine in the Bronx, New York. Dr. Cook is a health services researcher focused on improving quality of life and access and quality of treatment for individuals living with mental illness and substance use disorders. His NIH, AHRQ, and foundation-funded research tracks healthcare disparities in the United States and the impacts of health reform on disparities. His research also seeks to understand the impact of systemic and interpersonal discrimination on the health and healthcare of community members, and it evaluates the impact of hospital-based interventions on health equity. Ben, it's great to see you. Thanks for being here.
Thanks, Nick. And what an honor to be on this panel with you and Dr. Álvarez and Keuroghlian, and specifically with Dr. Alegria, who's been my longtime mentor and provided such a strong foundation for my work, as well as hundreds and hundreds of other mental health researchers. I wanted to first stress maybe start with the importance of tracking suicide rates, which I think is at risk. Some of these nationally representative surveys that are out there, and really push for ensuring that we continue to have high quality nationally representative surveys and measure race and ethnicity and gender and language. As Dr. Smoller mentioned earlier today, suicide rates among young folks 10 to 24 years old increased significantly among the Black population, a 37% increase between 2018 and 2021. Rates are up 5% overall in the 25 to 44-year-old group, but 34% for American Indian, Alaska Native communities, and up 20% in that age group for Black and Latino communities, as well as multiracial communities. So that the increased attention that we see to suicide in the U.S. has only been made possible because of these very well-designed, nationally representative surveys. Another area that I wanted to highlight of our work was we work really closely with the Cambridge Health Alliance Department of Psychiatry and the leadership there, as well as patients and family partners in our healthcare institution. We do that, we develop and we test and implement healthcare system-related interventions, implementing measurement-based care. We have a computer adaptive screening in schools. We evaluate different types of integrated mental health treatment, all with a focus on equity. And just to put another plug here, for better or worse, healthcare systems are spending enormous resources in our countries. We know they take up a lot of our GDP. They're also just very powerful players in health and now social services. They're starting to get into housing, they're into food security as well as healthcare. And that, for better or worse, might not be, that might not be the area that we want them, and that might not be the right player, but that's where we are. And in a way, it may be easier to move healthcare systems that do have such a large net. It may be easier to move them than large state and federal institutions, especially given how difficult it is politically to move things in state and national congressional legal systems. Another area that I wanted to talk about was we built a data warehouse that links electronic health records, claims, police data, jail data, school data, and individual and neighborhood level social risk data. And we use that data to enter into machine learning based prediction models to predict suicide, opioid overdose, other negative mental health outcomes. And I feel it's really necessary to do more of that work to link data across social service systems. As hard as it is to maintain those data use agreements, I feel like it's really important. The other one is I wanted to put in a plug for your work, Nick, and I hope you'll get to talk about this some more. But Nick's been working with David Williams and Todd Reed at the Harvard School of Public Health in developing a phone app that integrates passive data collection, such as movement and as people move through different neighborhoods, with other ecological momentary assessments of self-reported well-being and symptoms and suicide thoughts, with questions about discrimination and daily experiences of discrimination, in order to develop better real-time models of suicide. I don't think we have enough information about the ways in which experiences of discrimination underlie suicide thoughts. We don't have to look far to see the everyday nature of racism and race baiting in the US, how much it's in the air we breathe. Even now, the amplification of this racist trope of Haitian immigrants during last week's debate is now just everywhere. I mean, the funny memes about cats and dogs is just not a joke for a lot of the Haitian patients that we work with at Cambridge Health Alliance, and then has real consequences on the threat of violence for Haitian immigrants. So thinking about that kind of data and getting real-time data, and thank you to Dr. Whiteside and Matt Knox's work on showing how the time scale of severe suicide states is very short. Trying to understand how discrimination enters into those short time scales, I think, is really important as we try and understand better these feelings of hopelessness and rage that racism and discrimination can drive. So I hope Nick will get a chance to talk some more about that work, and really looking forward to the rest of the speakers' comments. Thanks, Nick.
Thanks so much, Ben. That's really powerful and really helpful. I appreciate there's some questions that are starting to filter in so far, and I found it really helpful when our panelists in the last panel contributed some answers. So if you can see those to our group, please feel free to chime in. Specifically, someone's looking for the name of the legislation that Dr. Alegria mentioned. So next, I'm really happy to introduce Dr. Kiara Álvarez, who's an assistant professor in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. She's a licensed psychologist. Her work focuses on mental health equity for children, adolescents, and young adults, with a particular focus on the prevention of suicidal behavior, the integration of behavioral healthcare across clinical, school, and community settings, and the mental health and well-being of Latinx and immigrant youth and their families. Welcome, Kiara.
Thank you so much. Wonderful to be here with all of you. And I think joining in just the gratitude for the many members of this panel and the work that they've done. I spent many years at MGH, both as a postdoctoral fellow and on a K23 award mentored by Dr. Alegria, and just with wonderful collaboration and support as well from Dr. Cook and Dr. Carson. And so I'm very grateful to then be on this panel to get to talk about some different perspectives on such an important topic. And the area that I want to cover, I think in these 5 minutes, is really going to be moving then into intervention research. And so I think hopefully building on the important points that have been made about the broader picture of policy and infrastructure in the US, as well as the data that we need. In the area of intervention research, I think we, I bring this up because it's important to take it in context with, I think, a lot of the great work we've been hearing about in implementation. And we need to understand that intervention research in the area of suicide prevention really starts already at a bit of a lag, because for many years, folks that reported suicidal ideation or behavior were excluded from clinical research studies, from mental health studies, because they were considered too high risk, to be included. And so for that reason, for researchers that were doing work in that area, it was an uphill battle to be able to get the work done. And we just haven't been able to get to the level of evidence, the level of effectiveness research that we have in some other areas of mental health. And so when we think about implementing interventions, about widely disseminating, we're usually looking for things that have really been sort of tested, well, and have a good quality of evidence with them. Whereas in suicide research, we're often doing this work in balance. We're working to get the best possible evidence, but also working to get things out into people and into communities, because the urgency is there, right? And the pace of the research needs to keep up with the needs of communities. So when we look at racial ethnic disparities, it becomes even more magnified, because minoritized populations have often been excluded or represented in small numbers in mental health research studies and intervention studies. And so we don't necessarily have a great understanding of what works for some of these populations that are either at very high risk or what communities may want, what kinds of interventions may seem acceptable to them relative to what researchers may think would be a good idea for that community. And so in my area of youth suicide prevention research, we really see this, where we're looking to think about how we can get better interventions out that are culturally competent, that are structurally competent, and also how do we do this implementation research to ensure that we're doing the work in partnership with communities and with clinicians. So I find that we have to hold this balance of doing this work. And it's very important, because what we know is that there are massive racial ethnic disparities in mental health service use for youth with suicidal ideation and behavior. We have data showing that, for instance, Black and Latinx youth use of psychiatric emergency departments continues going up. But at the same time, they're underrepresented in outpatient mental health. So they're not really getting the ongoing specialty care that they might need. And they're having to show up to emergency departments in times of crisis. And it's good that the emergency departments are there for them as an option, but it's really not what we would prefer for people to be using if they can access other options that might prevent a crisis and might keep people in their communities. And so we need to think about what will be these interventions, as well as how do we improve that mental health services continuum, I think, as Dr. Alegria was alluding to ensure that everyone receives that quality care, both in a crisis, but also to prevent further crises from occurring, and to really focus on wellness, on recovery, on empowering individual patients. And so linked with that, the other point that I want to make is what is the infrastructure that's required to do this, and who does that include and exclude? And so when we think about conducting these large studies, especially something like an effectiveness implementation research study, which is complex and usually, requiring large samples of patients to be able to get the results that you might need to prove that intervention is effective. So it requires a large infrastructure, it requires collaborators, it requires a big research team, requires multidisciplinary expertise. So to intentionally include diverse perspectives, to get to that geographic diversity, because we know that rural communities, for example, have high risk, but are less likely to have those resources in terms of large research centers, in terms of being able to collaborate intentionally with communities. We really need, large grants, right? Large infrastructure from centers like this one, or from large educational institutions. And that's not available to everyone. So for example, for me, being able to develop, a career as an intervention researcher, as an implementation researcher in the context of a of a research unit that really had that long-term expertise that could mentor me in it in the context of a large academic medical center. That's quite different from someone trying to launch a career in this area, perhaps geographically isolated, without access to mentors, without access to people who can really advise them on all of the levels of complexity of this work. And we know that this work is complex at the pilot study level, where I'm conducting a pilot study, collaborating with pediatricians, with parents, with community health workers. Even with a small number of participants, the complexity and the need for resources is still there, and the need for that consultation and support. So I do see that what's very promising is some of the efforts that NIMH and other funders have made to create this broader infrastructure, funding the practice-based centers like this one, funding consortium collaborations that bring together groups of researchers and research programs around one topic. And these collaborations, for example, with SAMHSA, where I think we can look to, the work around first episode psychosis and how that went from effectiveness to very rapidly being disseminated across the country, and really to a practice-based focus as successes that we ideally can learn from to address racial and ethnic disparities in the interventions and the services needed.
Thank you so much, Dr. Álvarez. I agree. The practice-based research centers have facilitated so much collaboration and sharing and innovation. It gives me hope, which brings us back to our one of our comments earlier in the morning. So that was great. Thank you. Next, we'll hear from Dr. Alex Keuroghlian, who is the director of the Division of Education and Training at the Fenway Institute. He's the Michelle and Howard J. Kessler Chair and Director of the Division of Public and Community Psychiatry at Mass General, and the Associate Chief of Public and Community Psychiatry within the MGH Department of Psychiatry. Dr. Keuroghlian is an associate professor of psychiatry at Harvard Medical School and the principal investigator of the National LGBTQIA+ Health Education Center, with a research focus on sexual and gender minority health. Alex.
Thank you, Nick, and thank you to the organizers for having us on this panel. I'm really honored to be participating and delighted to be joined by such wonderful colleagues today. I'll be talking a bit about suicide risk and approaches that have been adopted specifically with regard to sexually and gender diverse people. And we make sense of the much higher prevalence of suicide attempts and suicide in this population compared to the general population, often applying a minority stress and resilience framework. The idea here is that sexually and gender diverse people, chronically, developmentally, from early childhood through adolescence and across adulthood, experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a much higher prevalence than the general population. And there's a real intersectional component to this, where, for example, the FBI has reported that African-American transgender women are among populations with the very highest incidence of hate crimes in the United States, even beyond what we see among white transgender women. All of this we consider external stigma-related stress that over time can take a toll for many people, contribute to disruptions in general psychological processes, coping skills, emotional regulation, interpersonal, that kind of chronic stigma discrimination, but that can perpetuate distress over time, like believing it's never going to get better, nobody can be trusted, no one will ever love me, for example. All the external stigma-related stress can contribute to internal stigma-related stress, internalized homophobia, internalized transphobia, believing all the negative things that society says about your sexual orientation, gender identity, gender expression, expecting rejection because you're so accustomed to it, and identity concealment to prevent mistreatment and abuse. And all this external and internal stigma-related stress, we think, is related to what we see in research and unfortunately in our clinical practices, which is a much higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders in many cases as a way to cope with all this stress, decreased self-care, decreased engagement in healthcare, including mental health care and primary medical care in the context of a lot of medical mistrust and medical trauma, and down the road, a much higher prevalence, various physical health problems as well. And we don't think about this simply as a minority stress framework, but a minority stress and resilience framework. This idea that minority stress can present as a crisis. It's also an opportunity to promote resilience and cultivate adaptive coping skills. That being said, resilience isn't a solution for structural discrimination that requires protective policies and non-discrimination laws. And we've done a lot of work on the mental health effects of gender-affirming care for transgender and gender diverse people. This is care that helps people move from living and being perceived the way they are perceived by society based on their sex assigned at birth to living and being perceived the way they see and understand themselves. And there are different components to it. There's psychological gender affirmation, social gender affirmation, legal gender affirmation, medical gender affirmation, surgical gender affirmation. And studies have shown that social gender affirmation is associated with much better health in adulthood, including decreased odds of suicidal ideation. Pubertal suppression is associated with better mental health, including decreased odds of lifetime suicidal ideation. We did a study showing that access to gender-affirming hormones from early adolescence across adulthood is associated with better mental health in adulthood, including decreased odds of suicidal ideation, and that access to gender-affirming surgeries is associated with decreased odds of suicide attempts, suicidal ideation, and a range of other mental health outcomes related to mood and substance use disorders, for example. It goes on in terms of the clear benefits there. That being said, this is care that has been restricted in the last 3 to 4 years in many US states. Over 22 US states have bans on gender-affirming medical care, at least for youth, if not increasingly for adults as well. And we're starting to see the effects of this in terms of really unfortunate suicide-related outcomes as well. So it becomes really important to do two things. One is to ensure that research is led by community, and doing that in the spirit of the centuries-old political adage, nothing about us without us, so that we're asking questions that are relevant to community and designing outcomes that are also ones that community is focused on in terms of improving well-being. It's also important to think about policy in that this is directly adversely impacting the mental health of this minoritized and frankly, very directly persecuted and oppressed community, and a need for clinicians and researchers of the community and working with the community to not stand on the sidelines, but to really be vocal in shaping the public discourse and influencing health policy with direct implications.
Thanks very much, Dr. Keuroghlian. Our speakers are representing in a very powerful way, as well as bringing their research experiences and opinions to our group. So this is wonderful. One way we could take our discussion as a next step is there's been some consideration of the types of data and information that we use in our research. And one of our questions does address data. This was directed to Kiara with respect to what type of data do you believe has the greatest potential to be explored and collected for personalized interventions and assessments? So maybe we could just take a minute to speak about data. Kiara, you might start with that, and I think Ben may have had some thoughts there as well.
Yeah, I think that it is really promising to have this collaboration between people that are really thinking about this just-in-time data, between ways that we can collect data on through smartphones, through more immediate and regular reporting, and to combine that with intervention research, because I do think that one of the challenges we often have for intervention research is we are testing it, at points in time, usually before an intervention, after, a few months later, and it's good to see that longitudinal course. But we do know that often in suicide research, once we start testing, most people do improve, symptoms improve, and we don't necessarily see a lot of differences between groups. And so that has been a challenge sometimes in trying to do large scale effectiveness research. And so more fine-grained data on how it's impacting youth and how it's impacting, at the daily level, or potentially the mediators of those intervention effects. I think we can really do a lot more with collaborating at the level of just-in-time intervention development.
Thank you. As Ben mentioned, at our center, we've been doing some work on using smartphones to assess experiences of discrimination among youth. And I was reminded there was a question earlier this morning about the intersection of suicide research involving individuals with developmental disabilities. That actually came up as a theme among some of the youth we spoke to, that they had experienced discrimination about not just the language they spoke or their gender identity or race ethnicity, but their their diagnosis, their mental health concerns. Using smartphones as a way to assess those types of exclusion experiences feels like a promising avenue in this research.
Nick, if I could say, this is an area where we have a huge gap in terms of research. We really don't have a lot of research on the disparities for people with developmental, or problems. I think this is, in terms of data sets, in terms of really having great research that tests, how much of a disparities it is. So I want to bring that in because it's just recently brought into the National Institute of Minority Health and Health Disparities to open that as one big area of research.
Oh, thanks for saying that. Good. So we should all be thinking about grants in this area. Ben, did you raise some comments about linking data across different social systems and healthcare systems? Anything more you want to say about the quality of data and the potential to improve research from that perspective?
Yeah, thanks, Nick. Yeah, I talked a little bit about the importance of nationally representative data, and as those of you who have worked with that data know that there are still a lot of limitations there, and a lot of folks who aren't represented. I don't know if you all have seen this opinion article in the Lancet with Drs. Friedman and Hansen and Dr. Gahn, describing the omission, what they call the erasure of Native American data from the conversations about deaths of despair, which got a lot of popular attention, but failed to describe how Native American mortality rates were just as high, if not higher, during the time period in the age groups that Case and Deaton and others who describe these deaths of despair have talked about. And that's true for the American Indian and Alaska Native population in general. Many of our studies just don't have enough data there. It's an omission and an erasure. And you could say that about a lot of data for those who are unhoused or have housing instability. You could say that about those who are incarcerated. That there really are not many studies. The studies that I know about that are in carceral settings are often very small in scope, not very generalizable. The quality of the data that are in jails and prisons is very poor. And then I guess the other thing related to what you were saying, Nick, is that there is this opportunity to link electronic health record data, claims data, criminal legal data, school data. And I think that makes so much sense and is so important, especially since we're doing predictive modeling and ending up missing so much of the data that ends up being important across these social service systems. And in a way, the notes, clinical notes, might be a real opportunity to identify some of these things in the absence of being able to link all these data. So we've spent a lot of time scraping notes and trying to identify folks who are transgender and gender diverse, who have had violence, victimization, who have had childhood trauma, who have had housing issues, who have had interactions with the police, and I think there's a lot of potential there. So I'll stop there and hear what others have to say about data. And thanks, Nick.
Thanks, Ben.
I would add, sexual orientation and gender identity data collection is still in its infancy in many ways. The only federal agency that's required reporting of patient SOGI data, as we say, is the Health Resources and Services Administration, the Bureau of Primary Health Care, that funds all 1,400 federally qualified health centers in the U.S. that serve over 30 million of the most socioeconomically disadvantaged folks. Started requiring reporting of patient SOGI data in 2016. And in that first year of the policy, we published on the sort of national completeness of that data, and it was less than 30% completeness nationally. 6 years later, we followed up and published again in the American Journal of Public Health, and it was completeness nationally of over 70%. So that's dramatic improvement, which goes to show if you require the reporting, provide the training and technical assistance and support for health systems to do it, it's doable in vastly diverse health centers in terms of population level, race, ethnicity, urban and rural communities, and mostly cisgender straight people reporting their sexual orientation and gender identity. Even how we collect gender identity data accurately and representatively is an area of spirited debate. There was a National Academies of Sciences, Engineering, and Medicine consensus report published 2 years ago that included a lot of great people on the committee, but raised more questions than it answered in many respects. And there was a lot of controversy even after that occurred. It's an area we're very focused on in our group in terms of refining approaches for that data collection. And it's been politicized, unfortunately. The CDC's Youth Risk Behavior Survey, for example, has a SOGI module implemented in less than 20 states across the country, and certain states like Florida, for political reasons, pulled the SOGI module and actually pulled out of the YRBS altogether, like Florida a couple of years ago. So it is a way to, I think, intentionally achieve erasure, like Ben was saying, of a certain populations. We like to say, if you're not counted, you don't count. If we don't know who our trans and gender diverse patients are, we can't understand their health needs, and we certainly can't develop responsive population level interventions.
I just wanted to raise the issue to the group of the importance also of making sure that who gets that data. Because I think in one of the meetings I was in, one of the concerns we're seeing more and more is people being very concerned, even of race ethnicity data, of bringing it up because of the worries that they're going to be followed, that they're going to be identified. So I think we not only have to get better data, but also make sure that the government does not get that data for the wrong reasons.
Thanks, everyone. We're going to turn to some questions from our audience in a minute. But one theme that's come up that I think important to spend a few minutes on is the importance of collaborating with stakeholders in the community. Some of you have mentioned collaborating with individuals with lived experience, with clinicians who are providing care. There's some comments in our chat that are asking about individuals with physical disabilities, with those who are incarcerated. So perhaps we could ask for thoughts on the benefits and the challenges of collaborations of this sort to improve the research we're doing.
Yeah. There's a story in Stat News today that I was interviewed for about a retraction of a study that was published by a Springer Nature journal on this idea of rapid onset gender dysphoria among teenagers. And it implies this sort of notion of rapid onset gender dysphoria, that this is a product of social contagion and that people aren't really trans or gender diverse if they're not clearly and consistently expressing that from the time they're very young children. And this study was retracted, and there's a lot of controversy related to it. Editor of a journal resigned, and it's been kind of going on for a year. And the focus of this Stat News story and what I shared was that there's really a welcome shift in recent years towards understanding the importance of community-led research and not doing research on communities, but with communities and by communities. Otherwise, you end up with these really harmful papers and notions that get propagated that are not congruent in any way with community-voiced priorities and needs. And it's been heartening to see in recent years, with generations of researchers coming up, there's much more appreciation, the importance of having community involved in leading the development of research questions, funding decisions, even design of studies, planning, implementation of interventions, evaluation, reporting, and dissemination of findings. And there's no reason that any of those steps should happen without robust community involvement. And I would say that each of those steps is enriched and improved by community engagement. And it's great to see that there's a shift in this direction, but I think people who were not maybe trained in that research culture and to prioritize that approach end up in the kind of situation where they're maybe surprised by how their work is received, the way that happened with this whole retraction controversy over the past year. So I'm glad to see that academia, research, scholarship are really centering community voice and engagement in a way that hasn't happened before.
Kiara, did you have some thoughts you wanted to share here as well?
Yeah, I'm sure. And it was actually coming up for me even when we were talking about data, because I think one thing that's happened several times for me as well has been being in discussion, with a community organization, with representatives from a community that have maybe a program, something they're evaluating. And they've asked me, well, how do we talk about the positives? We think that we're doing a lot of good. We think that people are thriving. We think that communities potentially are moving, towards healing. And how do we measure that? And what are the measures that you all have developed, as researchers to be able to show the positives? And that's actually an area where we lack, right, a lot in research. And we really struggle with, we measure a lot of clinical outcomes. We measure things that are symptoms or other things, but we don't necessarily measure healing. We don't necessarily measure, empowerment, all of these other kinds of things that may be more salient and more important. And so it shows this gap in terms of what, what might be desired by communities versus what we're focusing our energy on, and what, we continue reporting in order to keep making the case, for the kinds of programs that we want to put forth. And so I think that question, as mentioned by Dr. Keuroghlian, of the involvement from the beginning, as well as the leading of projects, is very critical. And also the notion that, this isn't something that you sort of tack onto a project. It's really embedded from the very beginning in terms of your ethics as a researcher, in terms of how you're organizing projects and teams, in terms of how even folks that are coming up on the research side of things as research assistants or are being trained in how they're being treated, because everyone is a member of a community as well. And so many times when people are drawn to this work, it's because of a personal connection or experience, which is also relevant. So there's just sort of sometimes also that false, dichotomy between the researchers and the community members, and the expectation that researchers obscure their own identities or experiences. And I'm glad that we're seeing a move to that as well, to really claiming that the presence of lived experience, on research teams, and that researchers can speak to that without that becoming a source of stigma. But we still have a long way to go in that regard in academic settings. And there's certainly, I think, some of the real challenges of collaborating with community really get created by our administrative infrastructures. And so we have challenges with compensating people fairly. If people don't want to or can't disclose a social security number, there's limits into how much we can pay them, for example. So we might be paying research consultants, huge sums, and community consultants not so much. And so those kinds of struggles, I think, at the level of how the systems are created and how they support doing this work or not, can also really be a barrier that we could really be addressed at the level of institutional policy to support this work. But lastly, I would say that just really being clear and being specific about what community you mean and what community members you're engaging to represent that community, because they don't speak for everyone. And so knowing what that's bringing and what might be obscured or missed, I think, is also very important.
Thank you so much. So we have 10 minutes left in our panel today, and appreciate some of the questions and answers that have been provided in the Q&A. One helpful comment was to encourage the use of sensitive language when we're discussing things like neurodivergence, developmental disabilities, such as ADHD or autism, and just to be thoughtful about not promoting stigma with the language that we use in academic conferences such as this. So thank you for that. That it's always important to be thoughtful and mindful of the language that we use. There was a comment about how suicide research might continue to be leaving out individuals with disabilities with respect to obvious physical disabilities or those with invisible disabilities, and that this group experiences, as we've been saying, high rates of discrimination, unemployment, isolation, perceived burdensomeness, thwarted belongingness, aspects of the interpersonal factors related to suicide. I mentioned that Ohio State University has been working on virtual brief cognitive behavioral therapy for individuals with physical disabilities. So thank you for that recommendation. And I wonder, with the group, does this raise any other thoughts about inclusion or other needs for research in these areas?
I think we need a lot more modalities that are responsive to populations with disabilities. I mean, I think one of the things we have been talking about is, like people hard of hearing, how you also can do sign language to make sure that people get the information. I think the area of really trying to have people that might need to be part of the presentation. I think one of the things we don't do enough is have people with disabilities that are the actual messengers of the information and the actual people that have been involved in this, so that they can bring on their own perspective and help destigmatize so much that has been going on for people with disabilities. So I'm really I really think we need to incorporate them in not only academia, obviously, of the research, but actually as being the central figures running the research. So I find that that's a very different perspective when they're the ones running the research than people that are just consultants.
Thank you, Maggie.
And I might be trying to stitch too much together here, and don't want to stigmatize those with developmental disabilities, but their rates, like those with mental health challenges of incarceration and interaction with the criminal legal system, are higher than the general population. And doing the work to work on those things inside the carceral systems and inside criminal legal systems is really important. I saw there was a question about other work that's been done, and Kiara linked to NCHATS. Nick and I are involved in that NCHATS Center for Suicide Prevention in the criminal legal system, and have a project with the Cambridge Police Department for those people who are sectioned, brought in by law enforcement into the emergency department. We're going to try and give them patient navigators both inside the healthcare system as well as with the police department, social work staff, to try and make sure that they're getting the services that they need. So there are some examples, I think, of that, but that intersectionality when talking to police officers, when talking to ED personnel, is right away apparent, that the multiple identities and multiple needs of folks that are coming in with law enforcement is really important to get a handle on and to understand.
And
yeah, thanks for providing that link, Kiara. Go ahead, Alex.
We really have a long way to go in terms of disability inclusion in this area. There are a few fields that are more ableist than academic research and clinical medicine or clinical care. And to Kiara's point, so many of the structures in place are ones that are going to be implicitly or explicitly exclusionary towards people with a range of disabilities. So I find it, frankly, very challenging to think about how we can dismantle that to meaningfully and adequately have inclusion of people with disabilities in the process in a leadership capacity. And I don't have the answers, but I think it's important to not kind of underestimate the structural barriers we're up against on that front.
So we are 5 minutes away from lunch, and I want to answer one question that has asked if there are any programs that help individuals transitioning from residential treatment back to the community. I think this gets us back to a comment that Dr. Alegria made at the beginning about the $750 million that's being considered for community health centers in Massachusetts. as of January 2023, we have a statewide system of community behavioral health centers that provide 7-day-a-week access to urgent care for behavioral health needs. No appointment needed, just walk in. And I found that to be a really key missing piece in the mental health system that I think is relevant for individuals who have been in a longer term care setting, who need to get access to care quickly to reestablish outpatient therapy or medication treatment. So Maggie, I wonder if that leads to a brief discussion of other policy levers.
I think, this, like I said, this new parity can really be extremely helpful. And like you said, Nick, the community health centers are doing an incredible job, especially for ethnic, racial, linguistic minorities, minoritized populations. I actually think the next term is really getting the mobile units to be able to connect more people. And I love the idea of, like Ben was mentioning, of having navigators that can go where people are. Because I think part of the problem is the system is so fragmented that it's very hard to do that transition that the person was asking. We actually know that we miss a lot of people, even after they leave emergency care. That transition from emergency care to that 7-day window to get them directly into treatment gets missed by many, many people, particularly people that have suffer from any type of substance disorders. So this is an opportunity to make sure that either through mobile units or navigators, we can make sure that we connect people to care.
Thank you very much, Maggie. Thank you to everyone who participated in our panel today. Thank you for those who asked questions. This was a wonderful opportunity to talk about a very important aspect of suicide research, and I really appreciate the discussion.